Kia ora everyone, and welcome to this webinar on Dulaglutide and type 2 diabetes, brought to you by the Goodfellow unit and supported by Lily. My name is Dr. Grace Lee. I'm a general practitioner, and I have the pleasure of introducing Dr. Ryan Paul, who is an endocrinologist and diabetologist at Waikato DHB. Ryan also holds a number of positions professionally and recently convened the NZSSD National Guidance on the Management of Type 2 Diabetes. Over to you, Ryan.
Yeah, thank you, Grace, and kia ora koutou, everybody. I hope you're all staying safe and well during lockdown. I know it's been a busy time for many of you. Here are my relevant disclosures, and really just getting into it. We know that we've got, I guess, COVID at the forefront of our minds, but the prevalence of type 2 diabetes continues to increase. It's over 250,000 New Zealanders, and nothing's changed over many decades. About 2/3 will die from cardiovascular disease. So it's really important thinking about why do we treat diabetes. And it does create some of our greatest disparities for Māori and Pacific people. In particular, we know that Māori are more likely to get type 2 diabetes. They're more likely to develop cardiovascular disease and die from it, and also renal disease. And the figures are even a lot worse for Pacific. And really, it was a year ago, the only funded glucose-lowering therapies that we had that reduced cardiovascular disease up and above the effects on glucose control were metformin and empagliflozin. So we're really very limited compared to the rest of the world. So this year has been, I think, the year of change for diabetes care in Aotearoa, New Zealand. We've got, I guess, the predict cardiovascular risk calculators used by most of us. And what that shows in particular is we know that ethnicity, such as being Māori or Pacific, is not a risk factor for cardiovascular disease in itself, but it's all the other factors, that modifiable risk factors that go with it. I know being individual practitioners, we can struggle to change socio-demographic classes, but we can do a lot with our own individual prescribing. And we know that Māori and Pacific prescribe less of all basically the glucose-lowering therapies, ACE inhibitors and statins. The standard care that we know makes a difference. And there's been a commitment from Pharmac and Hiaka Hirunga, who are the body now that we work with Pharmac to really reduce disparities. So there's an ethnicity clause within the special authority criteria for both empagliflozin and Dulaglutide, which we'll come to talk about. And there's obviously the target advertising campaign, Your Health is a Priority, which you may have seen already on social media and TV. So from February, we had empagliflozin available, with Jardiance and Jardiamet. It's in combination with metformin, the trade names. And from tomorrow, we've got Dulaglutide. So this webinar is very well timed for that. So I thought I'd use a case and really just try to pick a common case for us all to keep at the back of our minds, and how what role does Dulaglutide have? How do we start it? So I've got Mrs. W, who's a 59-year-old Māori woman with type 2 diabetes, a history of hypertension, dyslipidemia, peripheral vascular disease, central obesity, and mild microalbuminuria. And HbA1c isn't too bad. At 63 millimole per mole. Remember, our target is less than 53 millimole per mole in most patients. And that's your current medication regimen. Here's Galvimet, Lantus, main glucose-lowering therapies. She sees the ad on TV and she makes an appointment to ask you about the new diabetes medications. And she is very motivated, as unfortunately, like many stories we hear, all of her whānau died in their 60s from MIs. So question, she asked, should she be on Dulaglutide or empagliflozin, and which one's better for her? And hopefully I'll answer that during this talk. So we start in terms of what Dulaglutide is. It's a GLP-1 or glucagon-like peptide 1 receptor agonist. Now, it's been available worldwide since 2005. And I've spoken to, I guess, many GPs and nurse practitioners over the last few months, and I still hear some stories about, I'm not going to prescribe these newfangled medications till they've been out for 2 to 3 years, just to see, what they're like and see what others experience with them. At this point, these medications have been used worldwide for a long time. Dulaglutide since 2005, empagliflozin since 2011. They're the most used medications worldwide for diabetes, in addition to metformin. So these medications have been used in millions of people. So I just want to get that message across, and they're well tolerated in the right group. So many of you will be scratching your heads and can't remember glucagon-like peptide 1 since med school. It is the main incretin, which is the gut hormone, which is produced by neuroendocrine cells in the gut in response to food. And what GLP-1 does is it acts directly on pancreatic islet cells, increases the glucose-dependent insulin secretion, and that's really important to think about because GLP-1 receptor agonists very rarely cause hypoglycemia because insulin secretion is glucose-dependent. So if the glucose levels are low, you don't get the increased insulin secretion. They also have other mechanisms, including decreasing glucagon production, so decreasing hepatic gluconeogenesis or glucose output, and also possibly preserving beta cell mass. So the key point, I guess, in terms of the hypoglycemia, the only cases of hypoglycemia in all the trials on GLP-1 receptor agonists have come in those on insulin and or sulfonylureas. So if you don't have patients on those, they're not going to get hypoglycemia. Just remember that. In terms of what is the incretin effect, so what incretins result in is if I give your body glucose, I'll give you the same amount of glucose basically eating or in through a drip, you'll get a much more, a greater response in insulin to eating or to the food that goes in orally. And that's all because of GLP-1 and GIP is other main incretin. Now, patients with diabetes, they have lower levels of incretins and actually on top of that, reduce action of incretins. That is one of the mechanisms that causes diabetes. If you might have heard of the ominous octet in terms of the mechanisms of type 2 diabetes. So all of a sudden, we've got a new medication that is actually treating the underlying cause of type 2 diabetes. We're not just putting an insulin, so to speak. But GLP-1 also acts elsewhere throughout the body as basically GLP-1 receptors in every tissue. And so it's really important to think of the whole body effects of dulaglutide. And the most important, and important in particular, is it acts on the stomach. And what it does, it decreases gastric emptying and slows the transit of food. So patients do feel a lot more full. And it also acts directly on appetite centers to reduce appetite on top of the reduced gastric emptying. So patients on dulaglutide typically lose weight, whereas I know many of our patients with type 2 diabetes unfortunately continue to gain weight. It also acts directly on heart and endothelium, and what you do as a result of that, you do get reduced cardiovascular disease. Okay, so all of a sudden you can see important extrapancreatic benefits. It also has protective effects on the kidney and why we see slow progression of renal disease. So these are all things we're trying to aim for in our patients with type 2 diabetes. This is just a pictorial showing the action of GLP-1. So it's normally produced by the gut. Here we're giving it as an injection. It's acting not only on the pancreas, but also the stomach, the brain, the heart, the kidney, and basically on all tissues. So one important thing to also remember is that in our bodies, GLP-1 is rapidly deactivated by the enzyme dipeptidylpeptidase 4, or DPP4. Now, so that's half-life actually in body. It's only about 2 to 3 minutes. Now, we use DPP4 inhibitors already. So vildagliptin is a DPP4 inhibitor. And what that does is it aims to prolong the action of GLP-1. Now, vildagliptin is, you could almost say it's a poor cousin of dulaglutide. But since dulaglutide is resistant to DPP4, you don't actually need vildagliptin any longer. It's completely redundant. You're just going to raise the potential for adverse effects. So one thing to remember is if you're starting somebody on dulaglutide, you need to stop the vildagliptin. And remember, it may be in combination with metformin. So that may push you to going to metformin alone. So this is looking out for both Galvis and Galvimet. So dulaglutide or Trulicity is the drug name. Okay, so it's easy to say. It does take a while to get your tongue around these names. So one important thing to know, it is only available in subcutaneous injections. Okay, the pen's very similar to insulin pens. I will show you a pictorial of that. And we've only got the one dose in New Zealand. It's a 1.5 milligrams once a week. So there are other doses available overseas, the 0.75 milligram dose, 1.5, 3, and the 4.5 milligram dose. Hopefully we will get the other doses with time. It's probably going to be realistically at least a year, but we've only got the one dose at the moment. And if you look at the previous studies comparing the 0.75 milligram to the 1.5 milligram dose, there's little difference in adverse effects. So, if we're going to pick one dose, it's very reasonable that we only have the 1.5 milligram dose available. So it can be injected any day of the week at any time of the day. It's the usual subcut injection sites, abdomen, thigh, upper arm. It's got an inbuilt 29 gauge needle. And I know many of our patients don't like injections. I always go through and talk about, I've injected myself with both. I still think pricking your finger hurts about 10 times less, 10 times more than ever giving yourself an injection of insulin or GLP-1 receptor agonist. So I think that's an important point to get across. And you shouldn't take two doses within 3 days or 72 hours. So if you do, if a patient has missed a dose, it's still okay for them to take them, next to, or the forgotten dose up to 3 days late. So the pens come in packs of 4. One pen, once it's out, can be stored at room temperature for 2 weeks. Otherwise, it's stored in the fridge. And as I said, we've only got one dose, so there's no need for dose titration at present. It does make things pretty easy from that point of view. So here's a picture of what the pens look like. And in terms of, you are obviously going to have to instruct patients on how to inject. I've spoken to Lily. We're going to have the patient information all ready to go, which contains the injection technique. There's also information available on Health Navigator. We've got that form already up to go as well. So what patients need to do is to basically take the black cap off, and you'll see up the top of the pen, there's a little, basically a red lock and a green open lock. They need to twist the pen to unlock, and then basically with the injection, in terms of to administer, they just push down, and when they take it off, it automatically retracts the needle as soon as you inject, and you can tell basically just by looking, if the grey part's visible, the injection's been administered. Now, still, the recommendation is for stool Trulicity to be disposed of in a sharps container. I know that varies from DHB region to region, how that process is rolled out. With the needle retracting, it's extremely unlikely. In fact, it won't happen that the patient will get a needle stick injury. So there are other options in terms of ice cream containers or milk bottles, but it's just following the normal processes that you have in your own DHB region. So everyone wants to know, I guess, what are the improvements in glycemic control? Now, it's like empagliflozin in that the reduction is directly proportional to your baseline HbA1c. So if you've got fairly good control at baseline, and let's take 56, for example, from the Rewind trial, which is one of the major trials on dulaglutide, there's only a 6 millimole per mole reduction. But for those that had, an HbA1c greater than 69, there's a 25 millimole per mole reduction on average. Some patients actually do a lot more than that. Others will do obviously less. But it's probably the agent, dulaglutide is probably the agent we've got that reduces HbA1c the most, except for insulin. Okay, it's our most potent therapy. And what's really interesting as well, if you look at the studies where they've then got insulin-naive patients with HbA1c above target, and they've given them dulaglutide versus basal insulin, those in the dulaglutide group have reduced their HbA1c further than those in the insulin group, so 12 versus 6 millimole per mole. There are likely many mechanisms for that. I think one of the big ones is basically no fear of hypoglycemia with the dulaglutide. You can be more aggressive. There are also other potential mechanisms that you can get increased postprandial insulin release and lower hepatic glucose output as well. So there are other potential mechanisms there as well. But all of a sudden, you can start seeing it's attractive alternative to insulin. I think what's really exciting is that if you've got a patient with an HbA1c to target already, and they're on less than 40 units of insulin a day, there is the potential to get them off their insulin. Okay, you can go backwards. Now, unfortunately, it's not going to work in those patients who have burnt out their beta cells, the end stage type 2 diabetes. If you've got a patient with insulin hypersecretion, you may well be able to get them off insulin. For empagliflozin, that's still a potential as well, but I have a guess that'd be around about 15 to 20 units of insulin a day if the HbA1cs are all ready to target. So we think about the other benefits. Now, the mean reduction in weight is 2 kilograms, and that's versus placebo in which patients gain weight, and that's at 5 years. And you may argue that's modest, but I will say it's all dependent on the lifestyle changes they make with it. Okay, so many patients will lose a lot more weight than 2 kilograms. Well, same token, many patients who don't change anything, their weight may not change at all. So it's still really important to emphasize lifestyle change for the new medications. So not a replacement for that. And I'll touch on that. There's also modest reductions in blood pressure and LDL cholesterol, which is probably part of the reason why we get a reduction in major adverse cardiovascular events. That's your cardiovascular death, your non-fatal MI and stroke. And the number needed to treat for that is 18 if they've got established cardiovascular disease. You've got to remember this is on top of standard treatments, on top of statins, on top of aspirin, on top of beta blockade ACE inhibitors. So it's another tool in the armory to further reduce that cardiovascular risk. And what's also exciting about dulaglutide is it's pretty much the only agent other than metformin and pioglitazone to some extent where we've got evidence that has a role in primary prevention. And so that's in those that are very high cardiovascular risk but haven't got known cardiovascular disease. We're looking at a number needed to treat of about 60 in that group. That's predominantly a non-fatal stroke. The Rewind study was designed for safety and not designed to show reductions in MI or cardiovascular death in those with I guess for primary prevention, but there is that potential there, and it is actually registered for primary prevention. Now, empagliflozin, and this might be one thing that influences you towards if you've got to choose between dulaglutide and empagliflozin. Empagliflozin doesn't have any evidence for primary prevention at present. It's only for secondary prevention. It's still a very good agent in secondary prevention, but there's no evidence to date in primary prevention. Dulaglutide also reduces the development of macroalbuminuria. Now, there's no evidence to date that's associated with a need for dialysis or renal death. It likely does, but we can't say that yet. Those studies are almost coming to conclusion. Whereas for empagliflozin, there's very good evidence that empagliflozin will prevent dialysis and renal death. So all of a sudden you can see that, hey, if I have to choose between dulaglutide and empagliflozin, that if the patient's if renal disease predominates, I'm going to be pushed more towards empagliflozin. Whereas if cardiovascular disease predominates, I might be pushed more towards dulaglutide. As I say, the benefits are additional to glycemic control and standard treatment. So no drug becomes without adverse effects. And the most common, I will say, and if you use it, you're going to see it because nausea occurs in about 8 to 30% of patients. Now, it's usually only mild, and less than 2% actually need to stop treatment because of nausea, and it typically resolves within the first few weeks. So I always warn patients that, it's very likely you'll get this, but just reassuring them that it's normal and will go away is often enough to get patients to get through it. I've got some other tips on how to reduce the nausea, which I'll talk about in a second. Now, it's much, much rarer to be associated with vomiting, diarrhea or constipation. But if you do have a patient that vomits, obviously you want to make sure that they remain well hydrated, because there have been case reports of acute renal injury in high-risk patients. But, they're your elderly patients on ACE inhibitors, non-steroidals, diuretics, just the normal red flags for that. So you want to be a little bit more cautious in that patient group. Transient injection site reactions can occur, and that's usually just a little bit of redness or nodules that once again dissipate. It's likely to be a lot less than other GLP-1 receptors agonists such as Byetta or Xenotide or Bydureon, but that may still happen. It's just reassuring patients that they'll go away as well. Now, if you read the adverse effects, you also see pancreatitis and medullary thyroid carcinoma. And I will say both of those are controversial to some degree. So all GLP-1 receptor agonists will increase pancreatic enzymes. And there have been cases of acute pancreatitis in basically the drug trials. But those cases did not come at a different rate to those in the placebo group. And the phase 4 studies have shown no increased risk of pancreatitis. Saying that, you'll be a little bit nervous, and you've got patients that have had multiple episodes of pancreatitis about using dulaglutide. The actual mechanisms are unknown of how it causes it. Similarly, increased risk of medullary thyroid carcinoma has only occurred in rodent studies. It's never occurred in the human studies. Now, I will stress that most cases of thyroid cancer are papillary or follicular thyroid cancer. You're very unlikely to see medullary thyroid carcinoma. If they do have a background of this, or if they've got a history of multiple endocrine neoplasia syndrome type 2 or MEN2 syndrome, once again, it's very rare. It's just you're not going to use it in this patient group. And I've already discussed before, the hypoglycemia only comes if the patient's on insulin or sulfonylureas. So in terms of tips to reduce adverse effects, so regards to the nausea, you almost treat it like, it's a patient with severe gastroesophageal reflux. You're talking about eating smaller meals, eating them more slowly, and trying to avoid food at least 2 hours before bed. And with that, you're trying to avoid fried, fatty, sort of spicy foods and alcohol and smoking as well. You're talking about, if they are nauseous, they do sort of maintain adequate hydration. Now, with regards to starting, I guess, dulaglutide and the risk of hypoglycemia, for a good bulk of our patients, they don't need any reduction in their insulin or sulfonylureas. But if you've got a patient that's high risk, and the best guide for this may be their HbA1c, or they may have blood glucose levels, between 4, 6, 7 millimole per liter, this is a time where you will reduce the insulin dose and the dose of sulfonylureas proactively. And a good ballpark figure would be to halve the dose of sulfonylureas and to reduce the dose of the total daily insulin by about 15 to 20%. So that's both, I guess, basal and prandial insulin. Now, that's just a ballpark figure. You will want to, the other patients that do need to keep monitoring their glucose levels to know basically where they fit. You do see the glucose lowering effects of dulaglutide relatively quickly, so you can ramp the insulin and sulfonylureas back up again. You may want to also at the same token reduce further if their glycemic control is too tight. So really, follow-up is very important. For vast majority of patients, a 3-month follow-up with repeat HbA1c, renal function, blood pressure, etc., is going to be fine. If you've got a high risk patient that you're worried about, the risk of hypoglycemia, the glycemic control, be more than reasonable to organise a phone appointment, either doctor or nurse led, within the first 2 weeks after commencing therapy.
Brian, do you think we could just pause for a second just to ask a few questions? We've had a few questions come up around dosing.
Yep.
So we know that currently we have one dose funded, the one dose funded. However, some people are asking questions along the line of, does it make a difference if we start at a lower dose? And what if we need to give a bigger dose? Are we allowed to double the dose of the vial that is currently funded?
Well, it's a single filled pen, and I think it'd be very tricky to administer a different dose to what's actually within the pen. And we've only got the one dose available in the country. So even though the other doses are available overseas, as I understand, we've only got the single 1.5 milligram dose in the country. Now, if you've got a patient that's paying for the dulaglutide, I guess theoretically they could administer double the dose in terms of 2 injections to get a higher dose. But unfortunately, I think we're going to be very limited to the single dose. But as I say, the studies haven't shown really any difference between the 0.75 milligram and 1.5 milligram doses in terms of adverse effects. So at this point in time, staying with the one dose, in many ways, it does make it easier as we get our heads around it.
Okay, great. And with regards to the potential side effects, someone's just wanting to know if this particular medication has any impact on renal function.
No, I would thought it would be, it's different to empagliflozin, where we see that transient reduction in EGFR before that. This isn't thought to cause any deterioration in renal function unless, I guess, there's dehydration or hypovolemia in that acute injury. And I'll come to renal function because dulaglutide is safe to use above an EGFR of 15 mil per minute. Okay, so with this is where we haven't done the studies and those on dialysis. So with I guess and we can't use empagliflozin with an EGFR less than 30 mil per minute. So all of a sudden we've got another group of patients, those are the EGFR 15 to 30, we've got another glucose lowering therapy in addition to low dose metformin, low dose vildagliptin and insulin. So it's another potential tool in that group.
Great, thank you.
That's right. And it leads on nicely to the next section in terms of precautions. I've spoke about those with an EGFR less than 15 mil per minute. There's also no safety data during pregnancy and breastfeeding or children, and it's less than 18 years of age. So I wouldn't not be using it in that group. There's a little bit of caveat, many of our children with type 2 diabetes, they're way bigger than us. And that's a group where you may want to have the discussion, they've likely finished their growth, they've gone through precocious puberty, but there's no safety data. I will stress there's no safety data in that group as of yet. With no data during pregnancy and breastfeeding, the other thing which dulaglutide does seem to be effective at is inducing ovulation in polycystic ovarian syndrome, and that's up and above the effects on glycemic control and metformin. So people are excited that there's potentially another treatment option in this group, but just to let you know, many of your patients who may not have been ovulating before starting dulaglutide may actually start ovulating, so you want to think about contraception and having that discussion.
So Ryan, sorry,
yep.
so Ryan, is there any teratogenic effects with this particular medication? I mean, there are plenty of people out there that potentially could get pregnant and
There
are
are
on contraception.
There are, considering this, there are some case reports of teratogenicity and miscarriage associated with the use of dulaglutide. But I will say that those reports in pregnancy, we're looking at, less than 100 pregnancies, and there will be thousands, if not tens of thousands, hundreds of thousands of pregnancies that probably occurred on dulaglutide. So there's no real, to be honest, there's no real safety data. The toxicity in animals is, we're talking much, much, much higher doses than what we get from dulaglutide. But I guess we're just saying, I can only advise you safety first, really, until we know more. It's probably safer than what's made out in the literature, but I can't give you a scientific answer for that. That's based on best guess. But it will obviously be important, as you say, talking about contraception. The other groups, in terms of those with adverse effects, we know, since it's going to cause potential gastrointestinal symptoms, those with significant gastrointestinal disease. And the big groups which is going to make it worse is gastroparesis, which isn't an uncommon complication of end-stage diabetes, and also severe reflux. I'll probably be steering away from that group. Sort of touched on the reasons why for those at risk of potentially getting dry and running into trouble that way, and also the previous pancreatitis and medullary thyroid cancer, or MEN2 syndrome. If you've got a patient that's had, an episode of gallstone pancreatitis or alcoholic pancreatitis, I wouldn't necessarily take that as a complete, contraindication. But it's just being cautious around that. There's also no real data for dulaglutide in type 1 diabetes to date. So I would really only be using this with specialist approval in that patient group. So when should you be using it? That's really the million dollar question. So I'll take you back to, I guess, our NZSD management algorithm, which I hope many of you have seen. There are, printable PDF versions which you can chuck up in the wall of your office. But just going through that, I want to hammer home really that metformin and lifestyle management are still first-line management in all patients with type 2 diabetes. Neither empagliflozin nor dulaglutide replace that. Okay, but what they both are is potential second-line agents for the treatment of type 2 diabetes after metformin. And if you've got patients, and basically the question you want to ask yourself is, does my patient have any evidence of renal disease? And that's a urinary albumin to creatinine ratio greater than 3 milligram per millimole, or an EGFR less than 60 mil per minute. So do they have renal disease? Do they have cardiovascular disease? And we'll just chuck heart failure into that for the moment. Or do they have a 5-year cardiovascular risk of 15% or above? Because if so, ideally, all these patients should be on either empagliflozin or dulaglutide, unless there are contraindications or they're not tolerated. Okay, so, and that's regardless of HbA1c and other glucose-lowering therapies. And that's slightly different to the special authority criteria, which I'll talk about in a wee bit. There's also the other group. You think, most of our patients don't actually have renal disease or cardiovascular disease or high cardiovascular risk. These agents, both empagliflozin and dulaglutide, sit alongside vildagliptin as a potential second-line agent. And I'll go through the exact patient groups for which they use it in. This is just basically just summarizing what I've just said. The clinical indications are the same. So you think about, do they have cardiovascular disease, renal disease, or high cardiovascular risk? And then, am I going to use it second line and others? Now, the biggest group is those that have overweight or obese with an HbA1c above targets, not at target, not like if you've got cardiovascular renal disease, but HbA1c above target on metformin alone. Because both empagliflozin and to a much greater extent dulaglutide will cause weight loss, whereas vildagliptin's weight neutral, and sulfonylureas, insulin, and pioglitazone will typically lead to weight gain, which most of our patients with type 2 diabetes don't need. Where you also might use these agents third line is if the HbA1c remains above target despite metformin and vildagliptin. And that is, because, we used to go, it was only about a year ago that most people in New Zealand went from metformin to sulfonylureas to insulin. Now, sulfonylureas and insulin are now moving, to third, fourth line agents at best, because we know that they potentially cause, they're still very good drugs, but potentially cause hypoglycemia and weight gain. Whereas these agents will cause weight loss, or may lead to weight loss, and won't cause hypoglycemia when used alone. So they have big benefits over the other agents. And on top of all that, they've got the benefit of reducing renal disease and cardiovascular disease, definitely in those that already have it, and dulaglutide those that don't. So these really are, we're talking about game-changing medications to what tools we had in the armory before for type 2 diabetes. But you'll see all of a sudden there is a mismatch with the special authority criteria, which I'm sure is on my next slide. And you'll now find that, you've been very good at starting patients on empagliflozin from February. All of a sudden you're thinking, hey, my patients on actually dulaglutide might be a better option for them. And in many of our patients, actually dual empagliflozin and dulaglutide therapy will be beneficial if the HbA1c remains above target. Now, if the HbA1c is at target, dual therapy is probably not going to do much, but if the HbA1c is above target, actually having both together rather than being forced to use insulin and sulfonylureas is better for our patients. But once again, we're not funded for that. And that's where this mismatch occurs with the special authority criteria, which is this. So it's only but all you have to know is dulaglutide's got the same special authority criteria as empagliflozin. Okay, so that's only in patients with type 2 diabetes. And they have to have an HbA1c greater than 53 millimole per mole for at least 3 months, and it's been on at least one other glucose-lowering therapy. It doesn't matter what it is. It doesn't matter if it's metformin, vildagliptin, insulin. It's just has to be one other therapy, and they must meet one other criteria. That is, they must be Māori or Pacific ethnicity, have evidence of renal disease, cardiovascular disease, high cardiovascular risk, and that can be on any standardized CV risk calculator, or onset of type 2 diabetes at a young age. Okay. Now, I tried to do the Dulaglutide special authority today, just out of interest. It's not ready yet, but I understand it will be from tomorrow. And what's important to know is that only empagliflozin or dulaglutide will be funded. Okay, you're going to have to choose between the two. This is purely based on money and financial ramifications. It's not evidence-based. So I just want you to know that we should be discussing self-funding when clinically appropriate. But with the special authority, there will be, as I understand it, when you do the dulaglutide special authority, there'll be a little box saying they're not on empagliflozin, and that will cancel their empagliflozin special authority. And the same with the empagliflozin special authority be updated. You have to say that the patient's not on funded dulaglutide, and that will then cancel their dulaglutide special authority, so to speak. So they can only have one special authority at one time, even though it's the same criteria. And so there's no reason why patients can't take both together, but the pharmacist will only be able to dispense one of the funded medications. Now, the list price for dulaglutide is a lot lower than, I'll be honest, than what we're expecting. It's $115 excluding GST, whereas the cost of empagliflozin, including GST, is about $85 per month. So it's going to be, if you're going to have patients on dual therapy, it's still going to be cheaper for them to get funded dulaglutide and to pay for the empagliflozin. Now, so with regards to self-funding, so which patients are you going to discuss? I think it's important to discuss it with every patient. I know, unfortunately, it's going to be outside of a lot of our patients in whānau capability for paying. I've always been surprised, though, how where patients in whānau get the money from somewhere, if it means that it comes with extra benefit and they can avoid insulin therapy. So the ones that are going to benefit, still benefit from empagliflozin or dulaglutide, is that those that have renal disease, cardiovascular disease, high cardiovascular risk that don't meet the special authority criteria. And they're going to be the ones that have an HbA1c less than 53 millimole per mole, or they may be the ones that haven't met, haven't been on HbA1c greater than 53 for more than 3 months. Now, you can do a special authority waiver. So somebody has self-funded empagliflozin and their HbA1 or dulaglutide, and their HbA1c was higher than 53, and now that you're seeing an HbA1c is below 53, you can do a special authority waiver, which means they can still get either medication. Okay, so it's just important to know that there is a separate form for that, but self-funding patients or previously self-funding patients can meet the funding criteria. So the other group I think will really benefit is those that are on, dual, having dual empagliflozin and dulaglutide therapy. So that's say for example, you've got a patient that's on empagliflozin and they've got cardiovascular disease and the HbA1c is above target. The next best agent to add in is dulaglutide, because they have synergistic benefits in reducing or improving glycemic control and reducing cardiovascular disease. Okay, and same if you had a patient which is on dulaglutide and the HbA1c was above target, the next best agent is empagliflozin. Now, there's no evidence to date yet there's a synergistic benefit on reducing renal disease. We're waiting. It's a watch this space type thing, but it's just thinking about if you're thinking best practice versus special authority criteria, that's what you'd follow. And it's great that for our Māori and Pacific patients and our young patients, if they're overweight and obese, they've got another agent, after metformin that you can use. But unfortunately for our non-Māori, non-Pacific patients, that's a group that potentially look to self-fund. And if they're normal weight, you're looking at an HbA1c above target, realistically, I think after metformin and vildagliptin. But remember, in that group, you're going to have to stop vildagliptin when you start the dulaglutide. So,
now,
sorry.
Ryan, sorry,
Yep.
just one
That's
question.
right.
With that waiver form, whereabouts do we find it?
I understand it's on the Pharmac website.
Okay.
I found this out the last webinar I've been done, because I must admit I've just done the special authority, but I understand there is a special authority waiver form.
Great.
That goes with that.
Okay, thanks.
So the biggest question, I guess, is do I choose dulaglutide or empagliflozin? And it's a hard answer to give a blanket or hard question to give a blanket answer to. There's no head-to-head studies directly comparing GLP-1 agonists versus SGLT2 inhibitors. So it's really going on, I guess, best evidence base. Dulaglutide will likely lead to a greater decrease in HbA1c and weight than empagliflozin, and does have that potential role in primary prevention. And that may be one driving factor behind your decision making. But really, it would often come down to the patient's comorbidities and what they want. And I think it's a really important discussion to have with patients. I've found many patients don't like taking tablets, and actually having a weekly injection appeals to them. What's probably slightly more common is that often patients dislike injections, that they're keen to avoid it if possible, and that might be the group you go for empagliflozin. But that is the group I would be talking, to about, the benefits of injection. The actual injection itself isn't bad. The bark is far, far worse than the bite. The other thing which I think you will need to emphasize in many communities is that dulaglutide is not insulin. There's still a strong fear of insulin out in the community. Mostly it's a good fear in terms of, the risk of hypoglycemia. Many patients know someone that's died shortly after starting insulin. It's about saying, hey, dulaglutide is not insulin. It's completely different. It's completely different, adverse effects. And when we think about the comorbidities, and I've spoken about this already, but those with heart failure or those with predominantly renal disease, they're the ones that you're going to be pushed towards empagliflozin over dulaglutide. And that's because there's good evidence that empagliflozin improves both, including end-stage heart outcomes, but it's not for dulaglutide. Saying that, dulaglutide has been shown to prevent strokes, but empagliflozin hasn't. So someone that's very high risk or has cerebrovascular disease, that will push you towards dulaglutide. As well as we'll discuss, if the eGFR is between 15 to 29 mil per minute, that's going to push you towards dulaglutide over empagliflozin, but we know it's safe. Now, the other part comes around to, I guess, the contraindications, precautions to use. So you can use neither in pregnancy, breastfeeding, or in children, or as yet, until we get that safety data. Now, we've spoken about for those with GI disease and with medullary thyroid cancer, not to use dulaglutide. In that group, we're going to use empagliflozin. On the same, I guess on the other side of the coin, for those that are very high risk of the adverse effects of empagliflozin, you're going to use dulaglutide. So the other people that I guess we've got the recurrent genitourinary infections that you're a little bit nervous about using empagliflozin in, dulaglutide is likely a much better option in those patients. The other group, which I really want to talk about tonight, is those on a keto diet. So we've had, this is just talking to colleagues across the country, we've probably had about 10 to 15 cases of diabetic ketoacidosis from empagliflozin. And many of those, well, pretty much all of those patients were preventable. And the two biggest ones were those on a keto diet and those, I guess, not stopping the empagliflozin when unwell. So I will stress that I know keto diet's a bit of a fad, places that those patients should not be on empagliflozin, and a much better choice would be dulaglutide in that patient group. The other risk factors, I guess you've got the high alcohol and type 1 diabetes that will push you probably towards dulaglutide over empagliflozin. And obviously, if you've got adverse effects on it's fine to switch. You may have patients, and I will, it'll be quite a few that will switch from dulaglutide to empagliflozin and vice versa. But I think this is probably the hardest question you're going to have in front of you in primary care. It's hard enough in secondary care, but I think it's it's probably the one thing to think about moving forward. So there are resources to help you answer those questions. If you haven't seen the NZSD guidance already, I would encourage you to have a look. It's tried to be sort of brief, pragmatic advice on all aspects of diabetes management, and there's sections on basically most things that you can think of with regards to diabetes management. Hiaka Hiranga also have a lot of information on there on the new agents and algorithms just to help choose. And I've also been developing health navigator pages for both there's patient-based information that you can print off on both empagliflozin and dulaglutide as well. I just thought I'd just show you just some pictorials. Here's the information on GLP-1 receptor agonists. Everything was spoken about tonight's on there. Jaakko Herdinger's got basically a whole lot of articles, or the very short articles in terms of all designed for primary care, in terms of helping, to get that information across, including algorithms, and the Health Navigator page as well, that you can just see that you've got a print off button there if the patient's in front of you. So I thought I'd get back to our case and really go through, how are you going to deal with it? And it's only, it's tomorrow that it comes out. So we've got, remember, if we get back to Mrs. W, she does have peripheral vascular disease. She does have an HbA1c above target with obesity and a little bit of microalbuminuria. Ideally, she should be on empagliflozin and dulaglutide. And it's about having that discussion with her. And she raises that she is anxious about injections, as her brother died a couple of days after starting insulin. But you go through it in a lot of detail, and she lights the greater potential for weight loss. She may be able to get off her insulin, and there is that potential data on preventing an MI with dulaglutide. So that sways her more towards that group. So remember, she was on Galbumet. So you stop her vildagliptin, you switch her to metformin alone, and you reduce the Lantus back by about 20%. And that's just because your HbA1c was relatively tight at 63 millimole per mole. And you show her the injection technique. It is very simple. And you do warn her. I think it's really important that you warn patients of the adverse effects and tips how to reduce it, because they're almost always, they will get through that transient nausea. Oh. So we'll go through. Ignore the bottom for the moment. That is your next question, though. But you organise follow-up, and since you're a bit unsure about it, what's her blood glucose level is going to be, you ask her to check her fasting blood glucose levels once a day, and you organise a phone appointment in 1 week. And her fasting blood glucose levels are now 3.8 to 5 millimole per litre. There's been a marked improvement. So you halve her Lantus further to 12 units. And her repeat HbA1c in 3 months is 45 millimole per mole, so she had a great success. So you stop her insulin and repeat her HbA1c in 3 months. So one, I guess, important change has been that patients should really have their HbA1c repeated every 3 months. If they're not to target, or if you've made a major change in treatment, well, once a to target every 6 months. Okay, so it's not just once a year at the annual review. And so this is what you've done on the next occasion. Your HbA1c has remained at target at 50 millimole per moles. Remember, most patients less than 53, and so you follow up in 6 months. But 18 months later, now I've taken a step forward in the future. Your HbA1c is 58 millimole per mole. And it's also remembering that type 2 diabetes is generally progressive disease without weight loss. Okay, you'll see these medications won't often change that, so you still need to keep monitoring them. So HbA1c is 58 millimole per mole. I've got a little question here to get a taste of what's coming next in terms of which is the best agent to add in now. You remember that she's on metformin and dulaglutide. Essentially, so only 2 agents. So you've got vildagliptin, pioglitazone, glipizide, empagliflozin, or Lantus. I'll give you a few seconds to think about that one. And I will say the answer is D, empagliflozin. If you can remember what I spoke about before. The reason why you don't do vildagliptin is that she's already on dulaglutide. Vildagliptin's going to do nothing, just potential adverse effects. The reason why I guess you're going to potentially stay away pioglitazone here, or you may be forced to use it if she can't self-fund empagliflozin. Remember that she will have to pay for one of the agents if she goes on both. Hopefully in 18 months' time, we'll have it off special authority, or at least have both available for high-risk patients, but we're not there yet. but pioglitazone can lead to weight gain, and you've got the other problems, adverse effects, such as osteoporosis, which you get a little bit more nervous about in postmenopausal women. Glipizide and Lantus both have potential increase or a risk of hypoglycemia and weight gain. So just remember that best practice would be for adding in empagliflozin in here. So I've got a couple of questions ready to end the talk, and there is a polling option, I understand, for you to enter. And I would encourage you all to enter the polls. Don't worry, it is anonymous. We'll never know your results. But this is hopefully the two key learning points that you take from tonight are within these questions. Thanks, Grace. I think Grace has just put it up. So there's your first poll question. So which one of the following patient groups will not benefit from dulaglutide at present? So you've got somebody that's got an HbA1c of 46 millimole per mole with a normal BMI and a history of ischemic heart disease. You've got an HbA1c of, second patient has got an HbA1c of 78 millimole per mole. They are overweight, and the HbA1c is despite metformin and glucoside. You've got an HbA1c of 56 millimole per mole, they are typically obese on just metformin alone. Next patient's got HbA1c of 92 millimole per mole, normal weight, and that's despite metformin, vildagliptin, glucoside, and Lantus. Or you've got someone that's got an HbA1c of 48 millimole per mole who's obese on metformin alone. So we'll give you a minute to answer this question. I know it's tricky. I deliberately made it like this. I probably overshot on a couple of the HbA1cs. But it's just think about which patient groups should I be using dulaglutide. And I'll go through each answer and basically go through why, the reasoning behind it. Do you have the poll results there? Is that all, Grace? There we go.
Get right?
Yeah, okay. No, thank you for that. Now, the answer I've got, the correct answer in terms of being E. Now, I know many of you put A, and actually, to be honest, A is not a bad answer either. So I overdid it with the HbA1c of 46. But one thing I do want to start people thinking about is if they have a history of cardiovascular disease or renal disease or high cardiovascular risk, these patients will still benefit from dulaglutide regardless of that, regardless of the HbA1c. Now, it's debatable once you get down to an HbA1c less than 45 if there's any benefit at all in cardiovascular disease. But this is a group, so argument's sake, we say the HbA1c was 50. This is a group which you still ideally treat with dulaglutide. Now, those with a high, HbA1c with overweight or obesity, and that's B or C, they're a great group for adding on dulaglutide as well as patient D, in terms of an HbA1c above target despite a pretty full regimen. Now, the answer why I guess E's the correct answer is that you'd only really use dulaglutide in someone that's overweight or obese if the HbA1c is above target. Okay, that's the group that you want. So for patient C, you've got the HbA1c of 56, that's above target on metformin alone. You'd use dulaglutide in that group. But if the HbA1c is the target, you wouldn't. Okay, so it's just thinking about where does it fit in, in terms of second and third line management. If you're going to do one thing as a practice, I'd just encourage you to prioritize those patients that are high risk, that have cardiovascular disease, that have renal disease, and making sure, if appropriate, they're on either empagliflozin or dulaglutide. And then as the other patients, as you work through them, what is the role of dulaglutide here? So we'll go on to the next question. So I did deliberately make them hard, so I will apologize for that. Hopefully this one's easier. So question 2. So which one of the following factors will not favor dulaglutide over empagliflozin? And so we've got 5 options there again. We've got A, a keto diet, B, heart failure, C, central obesity, D, primary prevention of cardiovascular disease, or E, cerebrovascular disease. So, which patient another way to ask the question is, which one of these patients would you choose empagliflozin over dulaglutide? And I'll give you a minute or so to do that. It is a hard question. Our patients don't typically come with one problem either. It's thinking about all the factors. No, very good. No, thank you. So I hope everyone can see the poll results. So the correct answer is heart failure. So if you're thinking about, if a patient's got heart failure or renal, bad renal disease, empagliflozin is probably going to be the best choice for them above dulaglutide. If they've got, otherwise you'd be pushed more towards dulaglutide, and that, particularly if they've got where weight loss is a big factor, or cerebrovascular disease, or that prime prevention, that's where dulaglutide sits. The keto diet, I just threw it in there because that's a patient group who you wouldn't want on empagliflozin. And other ones, I guess, the frequent genitourinary infections as well. But the other group where you'll be pushed more towards dulaglutide. So you probably had some experiences or not so great experience to empagliflozin. Here from tomorrow, we've got another option for these patients, and vice versa. You might have one or two patients where the nausea is too great for dulaglutide, and that's where empagliflozin will be a better option. But that's, well, I thought, so I thought hopefully we've got time for lots of questions.
Certainly do. I think we'll just take a question from the case that we just had before we backtrack into some of the questions around the medication, if that's okay.
Yeah, go for it.
So if self-funding wasn't an option for our previous patient, if they needed to go back on an agent, some would like to know, what else would you use in that instance? Yeah,
that's a good question. I have access to DEXA scans for free. So I tend to use pioglitazone probably a lot more than others. I think it's got a good drug, particularly in women who are insulin resistant. Saying that, you do need to be careful. I know that most people don't have access to funded DEXA scans in terms of watching any potential deterioration in bone density. And to be honest, that's a group where you probably end up on a sulfonylurea, either glipizide or glipizide. It comes down to, I guess, what are the other risks. Personally, I think pioglitazone's underused as a whole, but it's not without risks. And remember that you can't use pioglitazone in anyone with a edematous condition, such as heart failure, because it'll make that worse.
Okay. And just sort of thinking around the practicalities of access to the medication, we've had some keen punters out there trying to see if it's in stock at the pharmacies. Do you have any commentary around that?
Yeah, I will say, with the rollout of empagliflozin, wholesalers are probably a little bit underprepared for the demand. Everyone did really well in prescribing it fast. There was rapid uptake. So I've been assured on this occasion that wholesalers and pharmacies will a lot better prepared for dulaglutide being available from tomorrow. Saying that, I haven't physically seen the patient information booklet yet. It would be obviously great to hand that out to patients at the same time. But I understand that lockdown's probably had a bit of a hiccup. But I understand we're better prepared this time than we were for empagliflozin.
I think someone's just put a comment in the Q&A section, just perhaps reminding people to check with their pharmacist for the ETA. There is procurement potential issues apparently for this particular person. When they contacted their wholesaler, maybe 1 to 2 weeks away. Okay, yeah, well, I hope that's, I mean, we can only do what we can do. Exactly. But it's, hopefully it's not too long a wait. Now, just sort of moving back to the medication itself, someone was wanting to know, are there any drug interactions with dulaglutide? I guess it's potentially with regards to mainly around the adverse effects, in terms of making potentially those worse, around the GI disease, and I guess with insulin sulfonylureas, potentially the risk of hypoglycemia. Otherwise, I think they're pretty safe agents. To be honest, I'd have to look up the drug-to-drug interaction. But when I've been using the other GLP-1 receptor agonists, that list is very short. There's not nothing major
But I couldn't, to be honest, I couldn't give you a 100% answer off the top of my head. No major ones that I'm aware of, put it that way.
Fair enough. Now, how is dulaglutide excreted from the body?
It's renally understand, so it's fine in terms of final liver disease. Mind you, I don't think the safety has been studied in those with end-stage liver disease. So that'd be one group to exclude. But otherwise, it's I will say it's a well-tolerated medication considering what patient groups we can use it in.
Okay. Now, there were some questions around the use of dulaglutide in bariatric surgery or patients that have had bariatric surgery. Can you comment on that?
Yeah, it's still beneficial, I guess, is one thing. It's actually got a potential role. This is getting a bit off topic, but for our patients that have, I guess, hypoglycemia post-bariatric surgery. That's not an uncommon complication. So it has a role in both hypo and hyperglycemia. And I guess potentially it may help dumping syndrome in terms of that's an issue post bariatric surgery as well. It's just being a little bit more cautious in terms of delayed gastric emptying, but to be honest, it's not really an issue for our patients with bariatric surgery.
Okay. And how fast will you see the effects of dulaglutide on HbA1c level?
Yeah. Oh, I guess HbA1c itself, like anything, will take 3 months to change fully. So half your HbA1c changes in about a month, then roughly about 25% each month for the 3 months. That gives you your rough guide. But you will see the effects on glucose levels quite rapidly, and particularly if it has an effect on appetite and reduce intake straight away, you may well see effects within the first 2 to 3 days in terms of glucose levels. That will continue over the next few weeks in terms of lowering it down. But it's just being aware, those patients that have a rapid change in oral intake are the ones that are potentially going to, where you may be having to act more on their doses of insulin and sulfonylureas.
Okay, all right. And do you have any idea how long the patent is on for Trulicity, the current manufacturer in New Zealand?
No, I don't.
Okay.
Sorry. No, yeah.
There are a few questions just around some of the other medications which have similar benefits. So someone's wanting to know if liraglutide has similar benefits to dulaglutide.
Yeah, it's a good question. Now, liraglutide of Saxenda is not actually registered for diabetes in New Zealand. It is effective. I'll be honest, I use it off-label for my patients with type 2 diabetes and obesity in private. So it is a medication that is effective in diabetes. Saying that dulaglutide is a very good agent in its class in terms of one of the best performing in reducing cardiovascular disease and cerebrovascular disease. Liraglutide may have an advantage for weight loss with regards to, particularly you can go to the higher doses of 3 milligram a day, for example, for liraglutide, where we only have the 1 dose for dulaglutide. I would definitely not use both together. And dulaglutide actually provides, it's a funded option for these patients, and $500 a month is a lot for many patients, or most patients.
What are the other self-funded options in New Zealand at the moment?
Oh, you got liraglutide, which is roughly about $500 a month at full dose, and you've got exenatide. So liraglutide is a daily injection. Exenatide or Byetta is a twice daily injection. That I think roughly costs about $280, $300 a month. They've removed, since dulaglutide's come along, they've actually removed the long-acting form of exenatide or Bydureon from the market. So he's no longer weekly Bydureon. If you want a weekly GLP-1 receptor agonist, dulaglutide's the only option in New Zealand.
Okay. Now that sort of discussion around weight loss has brought up a few other questions with regards to the role of dulaglutide in weight loss without diabetes. Is there a role for it?
Well, I will say it's not registered for that in the country. I'm not aware of the data in that group. There likely is a role. I will say that for our patients with pre-diabetes, there's no indication as yet that the benefits of empagliflozin or dulaglutide outweigh the risks. So the only medication which I'll be using in patients with pre-diabetes, if you were going to use a medication, would be metformin or other pharmacotherapy for obesity, not for diabetes. So metformin remains the only agent for pre-diabetes. I would, this is just a personal opinion. If I was going to go for a medication, a patient without diabetes, they're going to have to self-fund anyway, I'd be discussing liraglutide over dulaglutide given it's registered for that and the extra benefits. That would be the politically correct answer, probably.
Okay, fair enough, fair enough. Now, just a question around storage. Someone wants to know, is it okay to get the 3-month supply of dulaglutide and pop it in the fridge?
Yeah, definitely. And who knows, we may be, with lockdown, if it spreads it, we may be forced into those sorts of avenues. Definitely find a store in the fridge. Just remember, I wouldn't leave a whole pack of 4 out at room temperature, just because it's only recommended for up to 2 weeks.
Okay, all right. And going back to your comment how dulaglutide is a good second-line medication, someone's wanting to know what would the third line of treatment be if someone still has suboptimal control?
That would be empagliflozin. If it's got contraindicated, if that would be what you go for. Now, unfortunately, that's not going to be funded for our patients, and that's when you may be forced to use pioglitazone or glipizide will probably be your next go-to.
Okay. Weight loss again is a theme in some of our questions. Someone's wanting to know how quickly can we expect to see weight loss if they're going to have it?
Well, that weight loss is at 2 years. I guess that 2 kilograms. With anything with obesity, you sort of talk about 3 months or 12 weeks being the magic response time. So if a patient hasn't responded to pharmacotherapy within that time frame, they're unlikely to lose weight longer. So if you were thinking about the weight loss angle, you'd see it within the first 3 months. And that pretty much applies to Duramine, Contrave, Xenical. It doesn't matter what you're doing. It's looking at that time for response frame. But the weight loss thing is really important. It would be great if we had a national intervention program in terms of lifestyle change. There's a lot of, hopefully everyone's aware of the DIRECT study, which is primary care led, in terms of, a low energy diet, which led to remission of type 2 diabetes. And a good number, a third at 2 years, which isn't small, shouldn't be scoffed at. And I think if we had something like that nationwide, that'd be great. I will say keto diet remains controversial. I know lots of people are using it, but if you look at the meta-analyses on keto diet, there's still no change in HbA1c or weight loss at 2 years. Saying that, some patients do very well on it, many others can't tolerate it, and that make up a very heterogeneous group. But it's just thinking, weight loss remains important. It's still our number one go-to for type 2 diabetes.
Now, you mentioned some potential issues with dulaglutide and patients that do have significant gorge. What if our patients are on acid suppression? Would you use it in that instance?
Oh, to be honest, I'd give it a go. I would. If it makes things worse, there's always the option of stopping it. And they may need to take sort of Mylanta or quickies for the week of the injection. If it was too bad, you could always, not give the second injection. But if they had, the patients I wouldn't use it, and put that way, it would be someone that had really severe GORD on treatment, or before or if they had severe GORD, you might start acid suppression first with the PPI, and once things are under control, then start the dulaglutide. You might delay it by a few weeks rather than just going gung-ho together.
Okay. You also mentioned that you can take this particular injection up to 3 days late.
Yep.
Now, when you're timing for the next dose, do you time it at 7 days,
or
or
you can still take it when the next injection is due.
Okay.
It's just probably, if you get patients to develop a routine and one day of the week's their injection day, that's probably the way to go.
Okay. And any hints on that issue of nausea if someone has a reduced oral intake for the first couple of weeks, particularly if they're still on insulin?
Yeah, I guess the other ones you want to warn, please contact the practice if you are having trouble, if you are having basically no appetite whatsoever, or if you are potentially going low, the ones you want to contact to cut back things further. I think the most important thing is to stay hydrated. They don't need to go overboard with the fluids. That can make the nausea worse. But if just as long as they stay well hydrated, the nausea is not usually that bad that it stops them eating. In terms of altogether. So it's just I think you just when you start off, just giving, I guess, patients some guidelines when to contact the practice if they're experiencing significant adverse effects. The vast majority will be fine, and particularly if you prepare them for it. It's only a handful which will be in touch.
Okay, all right. I do have a few questions that have come up around liver function testing.
Yeah.
One, can you use it if someone has deranged LFTs? And two, are LFTs a part of our monitoring or testing when we are putting people on this particular medication?
Yeah, it's another really good question. Because I will say the vast majority, or a good chunk of our patients, have fatty liver disease and have deranged LFTs as a result of that. If you've got known cause of liver, I'd push ahead and treat. If you've got someone that's got any signs of cirrhosis or liver failure, I wouldn't be treating them. But that's, once again, that's the vast minority. I guess I'm lucky in secondary care. If I've got someone with deranged LFTs, usually I've got an ultrasound that shows they've got fatty liver. I've got an ultrasound, they've got fatty liver disease. I push ahead. It makes fatty liver disease better. These are medications which do make a difference. If you've got a patient with undifferentiated, well, I think if you've got any patient with undifferentiated deranged liver function tests, you probably want to work out what's going on before you're necessarily going ahead. But if you've got mild derangement, I'd start.
Great. Well, we've almost just run out of time, actually. We've run to time, 75 minutes in. So I think we'll just sort of wrap the questions here at this particular point in time. So thank you so much, Ryan, for coming on board and delivering us your expertise on this particular topic. It's been really useful. And also for those of you out in the audience today, I know the last couple of weeks have been particularly difficult with lockdown, so I really appreciate you coming on board tonight and learning with us. Have a great night and rest easy.